Hello, everyone. Welcome to the third and final session in CADA's special three-part series entitled There's Always Evidence. I'm Nicole Mittman. I'm the Chief Scientist and Vice President of Evidence Standards at CADA, and I'll be moderating today's webinar. At first, I'd like to start with a territorial acknowledgement, and I'd like to encourage everyone participating today to think of the land where you are and the people who have been stewards of that land and our shared responsibility to preserve and protect the land for future generations. On that note, I wanted to let you know that I'm speaking to you from Toronto, Ontario, Canada, which is on the traditional territory of many nations, including the Mississaugas of the Credit, the Assiniboine, the Chippewa, the Haudenosaunee, and the Wendat peoples, and how many diverse First Nations and Inuit and Métis people. I want to acknowledge and thank the generations of people who have taken care of this land for thousands of years. So let's introduce this session. This webinar series was developed to put a spotlight on the wide range of evidence sources that can be used to inform decision making, and using it in relation to when gold standard evidence is like randomized controlled trials may not be available. We kicked off the series with Dr. Gordon Guyatt, an internationally renowned expert in and coined the term and concept of evidence-based decision-making. In part two, we had Dr. Amanda Sheppard and Sehar Jamal explore the added value and benefits of using observational and non-randomized studies to inform healthcare decisions and policies and practices. So just as a recap, Dr. Sheppard is a scientist with the Indigenous Cancer Care Unit at Ontario Health and is an assistant professor at the University of Toronto in the Dalla Lana School of Public Health. Sehar Jamal has extensive experience in using qualitative data and in the public health space, as well as using large and small cohort data. We're delighted to have them back for this third and final session of the series. Amanda and Sehar are going to be taking us into a deeper dive today into observational and non-randomized studies. So let's just do a little bit of housekeeping and formatting before we begin. This will be an interactive session, and you're encouraged to take full advantage of both the Q&A tab and the chat function. You can submit questions at any time during the Q&A or using the Q&A tab in the Zoom control bar at the bottom. You can also use the chat to share observations and comments all relevant to all participants. With the help of Michael Raj and Don Servo from CADA, I'll be monitoring what's coming from both sources, and we'll do our best to expand to your questions and comments, and we hope to get to most of them by the end of this session. Finally, it's a reminder that this session is being recorded and will be available on CADA's YouTube channel later on this week. It's really next to impossible on Zoom to give a warm welcome to our two speakers, no matter how deserving, but certainly with the high number of registrants, we're close to 1,000 individuals for this particular session. That certainly shows a level of interest and enthusiasm for this particular topic. So I'll stop and say, on behalf of everyone watching today, I'm very pleased to welcome back Amanda and Sehar. Thank you. Over to you.
Thank you so much, Nicole. That was definitely a warm welcome. Amanda, maybe we'll start with your disclosure if you want to just say a few words.
I don't have anything to disclose. Thanks.
Okay. Likewise, I do not have anything to disclose either. So we'll go on to the next slide. So just as a recap, if you'd attended the previous session that Amanda and I had done, we went over the different observational studies. So we talked about cohort studies, case control studies, cross-sectional, and then we dived into any potential way and framework to understand the associations between your exposure and outcome. So we talked about the Bradford-Hill criteria. So things like the strength of the association, the coherence, whether somebody can reproduce the results, or if there's a biological mechanism. So some of those things we touched upon. We also talked about biases, so selection bias, information bias, and the importance of confounding and how to control for that, especially when you're looking at research studies. And then Amanda's talked about the different tools that you can use to critically appraise research articles. So one of the ones that was CASP, And so what we'll do today is we'll walk through a research article that we've chosen based on COVID, which was the theme from last time. So we'll walk through that. We'll provide you with a summary of it. And then hopefully if some of you have read it, some haven't, they'll give you some understanding. And then we can participate in going through the CASP, the 12 different questions that CASP prompts to help appraise the study. Like Nicole mentioned, we do want this to be pretty interactive, so there are opportunities for polls that we have. So please participate, as well as we have discussion questions just to spark some interest and conversation. So feel free to participate in that, and we'll try to read some of those comments as well throughout the session. So let's get started. The paper that we've chosen talks about overcrowding in nursing homes, specifically around the infection of COVID and mortality in Ontario nursing homes. So we know that this is definitely a timely article, and something especially in Ontario and across the different provinces that are more populous, where nursing homes have taken essentially the brunt of COVID-19 cases. So this is really a good one, and it has been relatively recently published on November 2020. And was published in JAMA, so it's the Journal of American Medical Association, so a pretty good journal with a good impact factor. So let's go to the next slide. We can start talking about it. So what I'll do is I'll provide you with a summary in case you haven't read the article. So basically, this is a population retrospective cohort study. So if you recall from last time, we talked about cohort studies being prospective and retrospective. So retrospective was the one where basically the exposure has already occurred, and you're at this present state where the disease may or may not, some people may have the disease, some may not, but you're sort of going back to look at the exposure and line up the exposure with the disease. And so with population-based, meaning that in this study, essentially they've tried to include pretty well all nursing homes in Ontario. So it would be a good representation of nursing homes in Ontario. I think they left out about 5 nursing homes because of potential data quality issues. But apart from that, all the nursing homes are included within Ontario. And so the time period for this study was March 29, 2020. So that, I believe, was the first reported outbreak of COVID-19 within nursing homes in Ontario. And then they followed that till May 2020, lots of 20s there. And so if you recall from the last session, Amanda discussed the importance of a research question and how important it is to help you design the study, the different aspects that you need to consider, and also the interpretation. She walked through sort of different research questions her daughters had put up, her husband, as well as her dog. It's a pretty intelligent dog to come up with a research question. But so this article, the research question was, what is the association of crowding in nursing homes? So crowding was defined as the mean number of residents per bedroom and bathroom in the nursing home, and what that association of crowding is with nursing home COVID-19 mortality as well as incidence. So we'll think about that research question, and as we answer some of the CASP questions later on, think about whether that question was addressed and whether it was addressed in an appropriate manner. So we'll go to the next slide. All right, so the exposure and outcome are obviously really important. So in this case, the exposure was essentially the nursing home crowding index. So the authors developed this index, and it was pretty simple, and it is pretty reproducible as well. So that's a good sign. And so what their nursing home crowding index is the number of residents in the nursing home divided by the number of bedrooms. So they were looking at how many beds per bedroom, right? So whether there was single occupancy, so 1 bed per bedroom, or 2 beds per bedroom, or 4 beds per bedroom. And then also the number of bathrooms that were available to the residents. So that'll be the exposure. And then the outcome was the cumulative incidence of COVID-19 cases, so per 100 nursing home residents, and then also any associated mortality from COVID-19 per 100 nursing home residents. And so they figured out the COVID-19 cases from a lab confirmed case, so pretty validated measure. And at the time, the lab tests that they used were the ones that were used within the province and Canada in general. I know the testing has changed over time as the technology has improved for it. And so the way that they measured their exposure and outcome were through different administrative databases. So because it is a retrospective cohort study, we're kind of looking at other data sources to feed into the exposure and the outcome. So we'll go to the next slide. All right, so the exposure and outcome, definitely important, but of course you also have to think about other factors that may impact either the exposure or the outcome or just the entire relationship. So they categorized this in 3 different ways. So they looked at resident characteristics, nursing home characteristics, and regional characteristics. So resident characteristics were things like the aggregate age of the residents in the nursing home, their sex, their education, different comorbidities they may have, like dementia or diabetes, and then also their activities of daily living. So this information, just to inform you, came from what I believe in long-term care homes, they do a resident assessment test. And I'm not as familiar, so if you are more familiar with the long-term care home realm, feel free to comment. But this resident assessment test was, so this information was from a couple of years ago. So while the study was done in 2020, I believe these characteristics were drawn from data from 2018 or 2019. So just something to keep in mind when we're interpreting the findings. And then the second thing was nursing home characteristics. So they looked at things like the size of the nursing home, the ownership, so whether it was a for-profit nursing home or not, and then the standard pre-post 1999. So just a bit of context about this study. So these authors, their initial research question was whether COVID-19 cases varied by whether the nursing home was profit or not. And so they used the same data sources to answer that question in a different paper. And based off of that, they found that for-profit nursing homes tended to have more COVID-19 cases. And so that was their assumption, was that a lot of it is because a lot of those for-profit homes started or were built before 1999, before a lot of the standards came out and regulations came out for nursing homes. So things like how many beds, how big the dimension of the room should be, the ventilation, and all those sorts of things. So they knew that that would potentially impact the overcrowding index. And so they've controlled for that through that variable being the standard pre-post 1999. And so you can see that they've definitely thought of a lot of different ways to control for potential factors that may impact the relationship between the exposure and the outcome. They also looked at the staff to resident ratio. So something I want you guys to think about is, you know, in the news, it's also been brought up about how different staff can impact the rate of COVID-19 in nursing homes. So something I believe Amanda will bring up later on. So something to think about. And then lastly, the nursing home characteristics were around the proportion. So 1 bed per bedroom, 2 beds, 4 beds, and the like. And then the last was the regional characteristics. So they looked at the community that the nursing home was in. So what the cases were in that public health unit, for example, what the size of the community was, what proportion of people were born outside of Canada. So we know that ethnicity also has played an impact for COVID-19. So again, important factors to consider. And the one last thing I'll mention, which I don't think is on the slide here, but basically one thing that they mentioned was that, you know, COVID-19 entering into the nursing home can result in obviously snowball and more cases of COVID-19 in that home. But the COVID-19 entering the nursing home doesn't have anything to do with the overcrowding aspect of it. So they wanted to control for that. And through that, they developed a test variable, which was a negative control. And it's basically a variable to control for that potential confounding. And so they wanted to see the proportion of COVID cases that came in the low crowding and high crowding, whether those were similar. And if those were, then that's great. Then we know that it had nothing to do with the overcrowding relationship. So here, I think we have a poll, if we could pull it up. So now, given the information that you know so far about the study, what are your thoughts on the type of statistics that are going to be used? Are they going to be relative risk, odds ratio, none of those, or both of those, or what are your thoughts? So maybe we'll give a couple of seconds for people to digest the information and answer. All right, so whenever the results are at a good state, maybe we can look, all right, wow, it's 40% relative risk, 40% odds ratio. That's great. So yeah, so technically for retrospective cohort studies, you could do relative risk and odds ratio. For the most part, you want to do relative risk because there is that bit of temporality. So if we can have the next click. All right, so reviewing the statistics that were used for this study, quite a few different methods, and they were trying to control and be very mindful about many different things. So here, their main measure was the relative risk. So the risk of having COVID within the low overcrowding versus high overcrowding. They also use Poisson regression. So again, this is not really a biostatistic 101 session, but I just wanted to give you a brief understanding of each of the techniques they've used. So the Poisson regression is basically they were modeling the cases and deaths of COVID-19 based on the count. So the count being the number of beds within the nursing homes. And then lastly, they use logistic regression and propensity scores. So if you've read the paper or not, within the table 1, which is the standard sort of characteristics of the residents, they were looking at different variables, and they noticed that in table 1, amongst the low crowding index and high crowding index folks, there were a little differences. So there were differences in the type of comorbidities, there were differences in the education level. And so they didn't want those characteristics to impact the relationship. So they wanted to know that the relationship was any differences were due to the overcrowding and not necessarily the characteristics of the residents. So they did a propensity score, which is sort of a quasi-experimental when you know that the two groups are different. So you're sort of modeling it so that what would the results be if they weren't different? And so ideally you want to see that the trend is the same as regardless, and that would sort of give you an indication that, okay, so the characteristics didn't play that big of an impact on the relationship. And the last thing was the simulated preventable cases. So basically, for those interested, they did a simulation to see, okay, so if all the nursing homes that are here that have 4-bed rooms, what if they were simulated to just 2 beds per room? How many cases of COVID-19 would we have averted, or how many deaths would we have averted? So if we go to the next slide. Here are the results, which I'm assuming everybody's been waiting for. So over 600 nursing homes were included, which were about 78,000 nursing home residents. They had a range for the overcrowding index, so from 1.3 to 4. So 1.3 being mostly nursing homes were single occupancy, so 1 bed per room, to 4, where pretty well all the rooms had about 4 beds in, so relatively high crowding. About 50% of the nursing homes had high crowding index, so where the index was more than 2. So you're looking at largely 2-bed or 4-bed rooms. And you can see from this table the findings. So mortality and incidence both were significantly different between the low crowding index and high crowding, so almost twice the proportion of COVID cases. So if we go to the next slide. Again, so relative risks, these were the ones that were part of the study. They were looking at the relative risk of, so statistically higher risk, 1.73 for getting COVID-19 infection in the high crowding index. And we talked about confidence intervals last time, so here they are, 1.10 to 2.72. Doesn't include 1, so it is statistically significant. Whereas if you look at the mortality, relative risk, it does include 1, so very close to being statistically significant. So in that case, you kind of want to be mindful that, you know, there might have been some variance, but be mindful that mortality definitely does have, the high crowding index may play a role in the mortality, the associated mortality may not be statistically significant, but be mindful when you're interpreting it. And then the last, the simulation, they found that if they were to convert 4-bed to 2-bed, they would avert nearly 1,000 COVID cases. So huge number. So you can see the strong association between high crowding index and the risk of getting COVID or associated mortality, and then also averting about almost 20% of the deaths. So huge numbers. If we go to the next slide. So now what we'll do is we'll dive into CASP. Hopefully you've gotten a really good understanding of the paper. And so we can answer some of these questions and you can participate in the discussion. So we'll go through about 12 questions that CASP has provided to really help prompt us to answer these. To appraise this study. In CASP, there are different study types, so different types of questions based on the study. So we'll use the cohort study edition as it is a retrospective cohort study. And the three main questions the themes that we'll answer are about, are the results valid? What are the results? And sort of get us thinking about those results and whether these results will be helpful locally. So I know in the last session, people had brought up grade and whether grade could be used as well. So just to answer that question really quickly, if you haven't seen Dr. Gordon Guyad's session, feel free to go to that and see that. I know that it's recorded on the YouTube page. So that gives you a really good understanding of grade. But essentially, grade is more clinical, but it does have a lot of the same important factors to consider. So things around biases, the strength of the evidence and things of that CASP will also consider. And generally all critically appraisal tools do consider. So if we go to the next slide, the first two questions for CASP really help you think about how focused the study is. And then once you've answered those two questions, then you sort of can decide from there whether it's worth moving forward and spending time on the next 10 questions to appraise the study. So we'll go through the first two really quickly, and then we'll poll you and see what your thoughts are. And then we'll hand it over to Amanda, and she'll walk through some of her thoughts as well. So the first one is, did the study address a clearly focused issue? So here we want to think about what population was studied, the risk factors, the outcomes considered. So if we click, we'll see that we think that the study was very focused. They were looking at a specific population, being the Ontario nursing homes. It was population based, so pretty well everybody would have been accounted for. And they were looking at a specific association between overcrowding and COVID-19 incidence and mortality. So here we would check yes, and then move on to the next slide. And the second question is, was the cohort recruited in an acceptable manner? So here we're looking for any potential selection biases. We're looking for whether the people that are included are who should be included. And so if we click next, we'll notice that yes, population-based, so pretty generalizable. There's in a specific time period that we can locate, March 29 to May 20. And the information that was collected, something to think about was, as I mentioned previously, a lot of the resident characteristics and census data was a bit dated. So something to think about whether those have changed over time, or would those be pretty standard over time and not see that much fluctuation. So think about that when you're interpreting. But now I think we'll pull up the poll. And I believe, yeah, so whether you think, if you were doing this research article and you wanted to know more, would you continue with the appraisal? So yes, no, it seems like a poorly designed study, or not sure yet, potentially move forward. So we'll give people a bit of time to answer that. All right. Wow, a resounding 90% will say yes. So that's great, because we were going to do that anyways. We'll pass it over to Amanda, and she'll go through the next 10 articles, and I'll monitor the chat as well once the questions come up.
Great, thanks, Sehar. I'm glad everyone, well, 90% of you agreed to continue. So I'm really glad that you did a really thorough review of the paper. So whether people read it or not, hopefully that gives you a lot of ideas, so you can contribute to the chat boxes and ask some questions afterwards. So number 3, so we've decided to start section B of the CASP tool. So number 3 is, was the exposure accurately measured to minimize bias? So the hint here, look for measurement or classification bias. Did they use subjective or objective measurements? Do the measurements truly reflect what you want them to? Have they been validated? Were all the subjects classified into exposure groups using the same procedure? So could you go to the next part? Yeah, so there was a crowding index that was created that Sehar had described, and they did use the same formula to assess all the data, so the homes and the residents. We felt that the measures that were included were objective, so they were based from databases, including standards of nursing homes. Um, and our first thing that we want to have you put in the chat box is how is crowding measured elsewhere? What are other factors to account for in overcrowding? So if anyone has any ideas of what the authors could have done, we'd love to hear your perspective. I can
So,
see
yeah.
size of the room, residents per staff. Okay, great. So all good ideas. We were thinking, yeah, square footage per resident. One thing that we were talking about is maybe the crowding per floor. We're envisioning that some of these homes have multiple floors, and we were wondering if it made a difference if some floors were more crowded than others, and if that should have been taken into account. Sahar, any other comments?
Yeah, so people have mentioned the square footage per residence, the common rooms, ventilation. Um, yeah, so a lot of the things that you touched upon as well. And I think those are really important aspects and things that we were also thinking about.
Okay, great. So there's lots more questions, so we can probably hear more of your ideas as we continue. So next slide, please, and we'll move to number 4. Was the outcome accurately measured to minimize bias? So hint, look for measurement or classification bias. Did they use subjective or objective measurements? Do the measurements truly reflect what you want them to? Has a reliable system been established for detecting all the cases? Were the measurement methods similar for the different groups? Were the subjects and or the outcomes assessor blinded? So we didn't have that in this case. So if you could flip to the content. Yeah, so we were happy that all the tests were lab confirmed. In terms of reporting, the reporting was public, but we weren't sure about under-reporting, so that's something that left us with a little bit of a question mark. Sahar had mentioned that there were 5 nursing homes that were not included. I think the paper mentioned that the authors weren't able to assess the number of beds per room, so that's why they were excluded, but it would be interesting to learn a little bit more about those particular 5 homes and whether they were in the same region in the province. Um, one thing that we thought was missing overall was a bit more information about the denominator. So what I mean by that is, were all residents in these homes tested for COVID, or only residents that were symptomatic? And did some homes do multiple rounds of testing, or did others just do one round of testing or not at all? So that type of information that I think is really relevant to the outcome was not included in the paper. Okay, next slide. 5A, have the authors identified all important confounding factors? And I think some of them have come up in the chat box already. So here you would list what you think, and then also take note of important potential confounders that you think the authors missed. So Sahar, were there any that came out of the chat box that haven't been mentioned yet?
No other new ones. They were talking about different comorbidities and how they could make an impact.
Mm-hmm.
The deaths prior to the testing, I believe ventilation was something that
Mm-hmm.
came up. Caregivers and visitors.
Mm-hmm.
If somebody became ill and the roommates became ill, how did that? Volunteers has just come up as well.
Mm-hmm. Okay, great. So the authors did have that negative control that Sahar described, and they did do a good job of describing resident, regional, and nursing home characteristics. But yes, I think all those comments are completely valid, and would have brought more meaning to the findings. I'm just looking over my list here, just to add, it would be interesting if there was some kind of indicator that could identify which homes complied with the COVID-19 protocols. What about active screening? I'm glad there were comments about the staff and the proportion of staff that are full-time and part-time, and if there are a high proportion of part-time staff, does that mean that they're more likely to work at other homes? And I think I saw the word visitors come up, but yeah, when did visitors cease to come to the homes? And was that something that was directed by the nursing home itself, or was that a provincial order? We weren't too sure about that. So all of those things would have been really important to understand and see if they were different between the homes that are categorized as low versus high density. Okay, next slide, please. 5B, have they taken into account the confounding factors in the design or analysis? So here, look for restriction in design and techniques such as modeling, stratification, regression. Did they do a sensitivity analysis to correct, control, or adjust for confounding factors? And yes, they did. They did model the variables. There was a sensitivity analysis done. They did include that negative control. So what about stratification and subgroups? We thought that it would have been interesting if they looked at cases within homes by rooming variation. That wasn't really done to an extent. Another thing that we thought of in terms of the analysis is stratification. And the table 1 describes the comorbidities. So I'm glad comorbidities was mentioned by one or more of you, but because comorbidities would certainly be really important. And it showed that the distribution of dementia was different across homes. And we thought that that would be an interesting variable to stratify the analyses by. Okay, next slide. 6A, was the follow-up of subjects complete enough? The good or bad effects should have had long enough time to reveal themselves. The persons that are lost to follow-up may have different outcomes than those available for assessment. In an open or dynamic cohort, was there anything special about the outcome of the people leaving or the exposure of the people entering the cohort? Can I have, yep. So here we thought all of this was done very well. One suggestion would have been that it would have been nice to include a pre and post analysis. Now, these analyses were done in May, and that seems like a lifetime ago. And so much has happened in terms of the cases and policy changes in terms of COVID. So it would be great to be able to revisit this cohort and see what's happened since. Okay, next slide, please. So number 7, what are the results of the study? What are the bottom line results? Have they reported the rate or the proportion between the exposed and unexposed, the ratio rate difference? How strong is the association between exposure and outcome? Okay. So the results were that crowding has higher incidence and mortality from COVID in nursing homes. It was really great that the authors included both unadjusted and adjusted relative risks. So they did take into account all those factors that could have been confounders. So they controlled for covariates. And at this point, we were wondering from you, just in the chat box, other characteristics that you think would be different in the low and high crowding. I guess this might be more helpful for someone who actually read the paper. Competing factors of death, that's great. We know that comorbidity was something that was included. So thank you for that.
Yeah, one of
I
the
did.
other things mentioned, sorry, Amanda, was
Yeah.
that people in the high crowding situation likely differ from the low crowded in terms of the money that they invest in other aspects of health. They mentioned high crowding might be associated with less mobility and independence, which could impact, COVID-19, following some of the protocols as well for COVID-19, more direct patient caregiver interactions in low crowding scenarios. The ratio of the nurses to residents would differ between low and high. And the ability and speed of isolation would vary between the low and high, I assume, once a case has been diagnosed. And I think, just to answer, there was a previously asked question around whether they'd controlled for um, or whether they'd accounted for people who got COVID-19 and what the protocol was, if there was any sort of isolation and things like that. They didn't discuss that in the paper, but that's an important point to consider, and whether they had enough space or room to do that for high crowding versus low crowding. Another factor, a few factors that were mentioned were health conditions as a number of risk factors, disease introductions, contacts, visitors. So yeah, lots of different variables.
Certainly. And one thing that we wanted to point out that was significantly different in Table 1 was the variable for community population size. So it showed that more dense homes were in smaller communities. So that would have been interesting to explore further. Okay, next slide, number 8. How precise are the results? So look for the range of the confidence intervals. Sehar did read them earlier. And she showed that incidence, the relative risk was 1.73 and significant with the confidence intervals of 1.10 to 2.72. The mortality relative risk was sort of borderline significant. But we did think that the confidence interval were a little wide considering this huge sample of almost 80,000 people. So again, we're trying to include you in this discussion. One of the things we thought of, because there was so much variation in the characteristics that were outlined in the Table 1, that maybe because of that huge variation that has made these confidence intervals wider. But does anyone else have any suggestions?
It's a tough question, so maybe we'll give them a bit time.
So anybody have any ideas to why these confidence intervals are quite wide considering the high population included
So
in the
somebody
analysis?
mentioned that there are likely other confounders that may not have been addressed. Comorbidities could have a very large factor. And some are questioning the accuracy of the tests. More about presence of comorbidities.
That's great.
Yeah, I think the comorbidity speaks really well to the dementia point you brought up, and how that that comorbidity could impact COVID-19 protocols and things of that sort, and different floors as well. Somebody else has mentioned limited population versus all factors on the table. Maybe the truth is overcrowding has nothing to do with mortality. That's an interesting one. They might have defined low and high crowd thresholds differently. The social determinants of health and socioeconomic status. Maybe the frailty index could be accounted for, which is an important one for this population. One of the other ones, maybe not everybody else was tested for COVID-19, so only the symptomatic ones, like you mentioned, potentially. Somebody has brought up the point that it was relatively early in the pandemic, so a lot of the protocols were not as well defined as they might be now, which I think speaks well to the pre-post that we were talking about. It'd be interesting to see how the results vary by the lessons that have been learned. Yeah, a lot of different things coming in.
That's really great, everybody. And just to address socioeconomic status, yeah, that was not included at all. I'm just trying to remember. There was a variable for regional rates of COVID, so looking at sort of neighborhood characteristics, I guess, but nothing socioeconomic, which is too bad because I think they did have access to the census. The census was used for some of the variables. So room for improvement for sure. Okay, can we have the next slide, please? Number 9. So do you believe the results? Big effect is hard to ignore. Can it be due to bias, chance, or confounding? Are the design and methods of this study sufficiently flawed to make the results unreliable? In our last session, Sehar and I discussed Bradford Hill criteria. So thinking about things like time sequence, dose response gradient, are the findings biologically plausible and consistent? So with all those in mind, we did think there was a moderate strong association with the relative risk. Happy that they included that negative control. The results do seem to be validated in the literature, looking at other instances of crowding, for instance, the literature around TB. We thought that the findings were plausible. But definitely could benefit from considering other factors. And I think you've all participated in sharing some excellent ideas of factors that could have been considered. Can I have the next slide, please? Okay, so number 10, can the results be applied to the local population? Consider whether a cohort study was the appropriate method to answer the question. The subjects covered in the study could sufficiently be different from your population to cause concern. Your local setting is likely to differ much from that of the study. You can quantify the local benefits and harm. So for this one, we actually wanted to poll you and ask the question, are the findings generalizable to other jurisdictions in Canada? So if you could reply yes, no, can't tell. So I guess if you think about things like, was COVID-19 handled differently in nursing homes in other provinces and territories? Are there different room designs for nursing homes in terms of the number of beds per room? What do you think? Drum roll. A little split. So 46, about half of you saying yes, and the other half saying no or can't tell. So right away, I think we need more research if the results can't be generalizable everywhere, which makes sense.
I'd be curious, Amanda, just to hear people's comments, since I think we have a bit of time around. Of those who had said that the results may not be generalizable, would you be able to share why? That'd be interesting to know. So I think somebody had said that not all the provinces use the RAI, which I believe is the resident assessment instrument that was played into the resident characteristics. Another person has said that the management system in nursing home is an important factor. So that may, I guess, vary by different provinces. So that's also definitely plausible. Any other comments that people would like to share? Not all provinces or territories had outbreaks within the long-term care facilities, which is a valid point. Yeah, the standards and acts vary across the provinces. It's going by fast now. Some research supports not banning relatives, but including them in the infection control practices. Yeah, I think that would be an interesting thing to look at. It was a short study period. Yeah, I think the public-private discussion that's going on, I think these same authors have another study, which I'd mentioned earlier, where they looked at profit versus other types of nursing homes and how that COVID-19 can vary. So that might be an interesting one to check out as well, if that interests you.
And I think the findings there showed that it wasn't that what the characteristic that they really pinned it on was that these for-profit nursing homes were older buildings and therefore allowed for rooms with more than 2 beds, so had the 4-bed alignment. Okay, so why don't we go to the next slide? Thanks, everybody. Do the results of this study fit with other available evidence? And I think we've started to touch on that, but can we see the next comment? Yeah, so there are systematic reviews that have been done that show the spread of airborne respiratory conditions in nursing homes. So there is a literature to build on. When I was thinking about this, I had a visual of, the military style rooms with like bunk beds. I don't know if rates of infection spread have been evaluated in a military setting. I was also thinking about prisons. I've seen a lot of attention to prisons in the media. I don't know if that's been translated into the literature yet, but that would be really interesting to learn about. But yeah, I don't know if anybody knows more about that. They wanted to share. Oh, crowded spaces, meat processing, mines. Yep, so definitely occupational. There's a lot of occupational data that would support this too. Colleague of mine's father works in a factory and contracted COVID. And even if you think about a factory environment, is it because of how people are close together when they're doing their job, or is it because they break in a small room together at the same time? So again, lots to consider and think about. New recruits, I see that well-known issue among new recruits, and I guess the new recruits would be more likely to, the military new recruits would be more likely to be living in those sort of bunk bed style living arrangements. Okay, thanks everyone. Next slide is the 12th and final question. So what are the implications of the study for practice? So consider, one observational study rarely provides sufficiently robust evidence to recommend changes to clinical practice or within health policy decision-making. For certain questions, observational studies provide the only evidence. Recommendations from observational studies are always stronger when supported by other evidence. So can we see the, thank you. So how many studies are enough? When do you stop? So, is this, we had the question when we polled you about does this apply to other jurisdictions? Less than 50%, I think 47% of you said yes, but for those who don't think so, then you would probably want another study, right? So how many studies need to be done? And we just wanted to, if you could click the slide again. This study impacted policies upon completion. So early communications of these findings did lead to maximum room occupancy caps for incoming residents in Ontario, and that started in June 2020. So even though I think we've done a really excellent job of sort of picking this paper apart, there were some policy changes that were made as a result of this work. So one of these hints is about one observational study rarely provides sufficient evidence to make changes. Well, this one does. So I'm glad we picked it to read. Okay, next slide, please. So I know there's probably a lot of answers in the chat box. How would you improve this study? Really appreciate all your excellent ideas. If we could hit the slide again, these are some of the ideas that Sehar and I had. So doing the pre-post lessons to talk about the issue of ventilation. That must be something important to consider. What about the cohort? Could the cohort be designed differently? Consider what about excluding people with who already had COVID? Would that change findings at all? And then more detail analysis with subsample of nursing homes for patterns. So, this was a population-based approach, but maybe if a couple of nursing homes were selected in different regions in the province, maybe we could learn even more about what's happening on the ground. And I would actually make a case that this would be a great opportunity for qualitative research and to find out more about the characteristics of the residents and the staff, and what are the themes that evolve in terms of life in these nursing homes, and where are there potentially areas that could be modified to make everybody safer. So Sehar, have you been looking at the comment box? Are there anything else to add about improving the study?
I think people had some questions
Mhm.
just around whether the policy change was actually due to the urgency of COVID-19 or in the absence of evidence, or is it actually because the quality of the paper was good, which I think is a really important question. And I think from my perspective, really quickly, it's probably a bit of both. I think because it was just the beginning of the pandemic, that's why I think the post lesson would be interesting to see whether the impact remains once the protocols have been more enforced within nursing homes. But what are your thoughts, Amanda?
Yeah, I don't think we have the answer to that, but I would just say that I think if these authors left the analysis at the modeling and logistic regressions, et cetera, and didn't do that simulation where they actually showed the number of cases that could have been avoided and the number of deaths that could have been avoided had everyone been in a 2-bed room, I think that was actually a very impactful analysis to show. And I think that really contributed to the uptake of these findings, personally.
Yeah, and I think one last one that has come up here is like questioning the crowding index and how sensitive it is to the definition. So a suggestion was maybe just using the number of residents over the number of bedrooms, or so just picking either bedrooms or bathrooms.
Mm-hmm.
And then another point was ventilation. Yes, it's hard to quantify. The levels are surrogate, but not measured anywhere. So a lot of important things for people to consider if they were designing the study themselves.
Mm-hmm.
Yeah, but thank you so much, everybody, for participating, and Amanda for walking us through that.
Yeah, thank you, Sahara. It was fun. This is like the biggest journal club I've ever participated in.
Exactly.
I was about to say that this has been a very active virtual journal club, so that's fantastic to see. It's Nicole here, and I just thought maybe there's a couple of questions I've seen a little series of them as they've come through the chat function. What about other diseases, right? So you could have a very similar study, but have a different disease or condition. For example, in this case, influenza or Legionnaire's disease was the other example in the chat function. When you ask the question, is one study enough? Is there an ability to think beyond the actual condition, for example, and use some of that data as evidence?
Yeah, I think the actual disease is really important. I'm no expert, but I understand that Legionnaire's disease is extremely contagious, extremely airborne. So I think a study with Legionnaire's disease would have to take into account the ventilation of the facility, whereas influenza, it might be more protocols related to like what we have for COVID with wearing a mask and disinfecting. But I do think that the disease is relevant for sure. How someone just said TB. Yeah, thank you, Kathy.
Yeah, and to your point, Nicole, I think I agree with Amanda. The disease definitely plays a big impact, but to some extent, if there are similar diseases or similar infection routes and stuff, then I think you could maybe rely on different evidence to just say that yes, crowding definitely plays an impact on infections in general, and that's why we use sort of the example of TB and maybe influenza and things like that.
Perfect. And then maybe a more philosophical question. And one of the reasons that observational studies are lower on the evidence pyramid are because of increased bias. And we've seen, you've talked about examples of that as along the way, but also then the representativeness of the population is often more representative than that found in a clinical trial. And so what was interesting though is the discussion that I think there's nothing that's perfect. I think you've alluded to there, you know, is this study the right population? People have talked about whether it's the right cohort, it's the right timing. So there are still external validity issues or representativeness issues around even observational studies as well. So I think with that, very active, and thank you for those of you who have gone through the chat function. I know there's still some questions around confidence intervals and why didn't we use survival curves or survival analysis. So lots of things still to consider, but I really do appreciate the work that you've gone through as an audience, and then also for our presenters to actually help us walk through how to evaluate an observational trial. So that brings us to a close and to the end of today's session, and really the end of this series. Our goal was really to talk about and introduce folks to evidence beyond the randomized controlled trials and to show you how to appraise it and apply it. And in this case, we had a very active appraisal period, so that was fantastic. I think we've been successful, and if we've been successful, it's really because of Amanda and Sehar. And so a big thank you to them and their great presentations and willingness to participate in our CADIS webinar series as well. You will get a link to the evaluation in short order. Please let us know how we did and tell us if there are other methodological topics that you're particularly interested in having us cover. We're interested in looking at methodologies as well at CADIS. So thanks for joining us as well. And CADIS has other events coming up, so please keep an eye on your on the CADIS website for other announcements. And with that, and until the next time we see you, please stay safe. Thank you all.